Hello, welcome to this month's Simon Says Expert Series. My name is Jessica Loving. I am the program manager for our adolescent and young adult cancer program, also known as the AYA Cancer Program. Joining us today is Dr. Jodi Skiles, who is our AYA medical director, also the section chief of bone marrow transplant and immunotherapies, and a member of the IU Simon Comprehensive Cancer Center. And then we also have Michelle Hoffman, who is our dedicated adolescent, young adult, and survivorship social worker. We are very excited to be sharing with you today some information about the AYA cancer population in general, and then also some information about the specific service offerings that our AYA program has for our patients. We have about 30 minutes or so of content, and then we also have time at the end for questions. So we will go ahead and get started. Dr. Skiles, can you set the stage for us? What exactly is an AYA patient, and what is unique about this population of patients?
Absolutely. So the National Cancer Institute defines an AYA patient as any patient that is diagnosed with any cancer between the ages of 15 and 39. And that's a really broad age range, also a really broad diagnosis group. But we know that there are a subset of cancers that tend to show up in this age group. So the common ones are things like leukemia, lymphoma, sarcomas, and brain tumors are probably at the top of the list, but certainly any diagnosis can show up in patients that are in the AYA age range. And you might be asking yourself, why do we care about this particular age range separately from all other cancer patients? And the reality is that the reason why we care is because there are differences in survival and outcomes for this patient population. The reasons for that are multifaceted for sure. So these patients experience an inferior survival compared to both their pediatric and adult counterparts that have the same disease process. And we think that that's a combination of factors, including the actual biology of disease, and an AYA patient might be slightly different than their younger and older counterparts. In addition, there are differences in approaches to treatment between the pediatric and adult worlds, so how you are treated matters. Certainly adhering to the therapy that you are prescribed matters, and that tends to be more challenging for adolescent and young adult patients for numerous reasons. And then the other piece is lack of clinical trial enrollment for these patients. AYA patients tend to be underrepresented on clinical trials, which means that if they're not represented there, then it's hard for those trials to result in cures for AYA patients. The other thing is that cancer incidence in this age population is increasing over time. Cancer incidence for all populations is increasing over time, but disproportionately so in AYA patients. Again, there are probably a myriad of reasons responsible for this, but some of the ones that we know contribute are things like lifestyle and diet, the incidence of sexually transmitted infections like HPV. Certainly, genetic predisposition plays a role. And then we also have an increase in detection of cancer by our changes in screening practices over time. So that's kind of just a brief overview of what an AYA patient is and why it matters. And really, our AYA program has really been designed to sort of get at some of those gaps and shortcomings that we experience in AYA patient populations. So at IU, we have developed an AYA cancer treatment program that really has six main pillars to address all of these factors. So the first pillar is making sure that our AYA patients are treated in an age-appropriate treatment setting. So, for example, getting a patient to the right provider or setting that's most likely to result in a cure for that patient. The second pillar is making sure that there are clinical trials accessible to those patients and making sure that those trials are offered to patients so that we can learn more and do better for AYA patients. The third pillar that we'll talk more about later is fertility preservation and sexual health for this patient population, as well as the fourth pillar is psychosocial support. So making sure that we're providing wraparound services to support patients with all the things they need to be successful. The fifth pillar is making sure that we manage symptoms appropriately, and that includes the palliative care team that helps us support patients. And then the last pillar is really survivorship. So life after cancer, what does that look like, and how do we best care for these patients? So that's a broad overview of what we refer to as our AYA patient population and program. And we'll dive into more parts of these things that I've discussed as we go through the hour.
Excellent. Thank you. So you mentioned that the AYA age range spans ages 15 to 39. So when we think about the traditional cutoff between pediatrics and adult medicine, usually that's somewhere around the age of 18, which is not quite smack in the middle of this age range, but close to. So when we have a patient in the AYA age range who is newly diagnosed, how do we determine if they should be treated by a pediatric oncology team or an adult oncology team?
That's a great question, and one that I think all healthcare systems struggle with is how do you make sure that the AYA patient gets to the right provider on the first try? I will say it's an imperfect science, and we are constantly working to improve this process, but there are many factors that we consider when we are looking at where a patient should actually receive their treatment. So the first consideration is, what is their actual diagnosis? So, as I mentioned before, there are a number of diagnoses that are most common in the AYA population, but really AYAs can get any cancer. So, for example, we think of breast cancer as being primarily an adult cancer, but what do you do when a 17-year-old gets breast cancer? Well, I can tell you, as a pediatric trained oncologist, you don't want a pediatric oncologist treating a breast cancer patient. It's not our area of expertise. So making sure that we get the patient to the provider that is most experienced and has the right expertise to deal with that diagnosis is probably our first consideration. The other things that we consider for all of the diagnoses that span the age range and really show up commonly in AYAs, the next thing that we look at is, well, what treatment approach is most likely to result in a cure for that patient? So we look at the medical literature and what treatments are available for that patient to decide where the patient is best going to be served. We also take into consideration part and parcel with that is saying, well, what clinical trials are available? How can we make sure that AYA patients have access to the latest and greatest things that are coming on the leading edge of science? So we look at what clinical trials are available in each particular setting. And then the other two factors that play a big role as well are what psychosocial factors are present. So, for example, you might have a 25-year-old patient who's pregnant. Again, as a pediatric oncologist, I might have expertise in the diagnosis, but I certainly don't have I don't have expertise in treating a patient who's pregnant with chemotherapy. On the flip side, we may have an adult patient, like a 30-year-old, that has Down syndrome, who really needs extra supportive care in the pediatric setting where we're used to dealing with patients that have Down syndrome that need extra psychosocial support. And then the final piece of the puzzle is, what does the patient prefer? Because there are, all the factors that I just listed above certainly contribute to the picture, but if a patient has a strong preference on where they're treated, and that goes in both directions, then we certainly prioritize that as well. So if we have a patient that we say, well, based on your disease, you could be treated in both locations and be likely to experience similar outcomes based on the pediatric or the adult setting, and somebody has a really strong preference for being treated in the adult setting, that's completely fine. Even though we would maybe place a patient in a different place, if a patient has a strong opinion, we certainly give heed to that as well.
Excellent. Thank you. So you talked about age-appropriate care as one of our pillars. Obviously, clinical trials trying to expand the representation of AYAs in that clinical trial space. You also mentioned that fertility and sexual health is one of the pillars of our AYA program. So talk to us a little bit about why fertility risk assessment and support is so important in this patient population, and how do we in our AYA program help with that?
Absolutely. So fertility is really critical and paramount to discuss as early in the diagnosis journey as possible. And the reason for that is because that we know that all chemotherapy impacts fertility to some degree. And the actual risk is very variable based on the diagnosis and the planned treatment regimen, but we know that all patients are going to experience some impact to their fertility from their therapy. And so we really try to meet that challenge head on and have a discussion early, even though it's probably the last thing that many patients want to talk about right at the time of diagnosis. It turns out that when patients are finished with their cancer therapy, it becomes one of the most important things. Unfortunately, if we wait until the very end when treatment is done, many times it's too late to actually intervene and do things that can preserve fertility. So we try really hard to have that conversation as close to diagnosis as possible and offer interventions for preserving fertility right up front. One of the questions we often get asked is, how young is too young to talk about fertility? And the realistic answer is no age is too young. I can tell you in the pediatric population, we discuss this all the way down to infants. Literally every patient that walks through the door gets a fertility conversation. And the same is true for AYAs. The difference is that AYAs often have developed opinions about what they want to do with their fertility. So we try really hard to hear the voice of the AYA patient and support whatever their wishes are in terms of preserving fertility. Now, it's important to note that I could talk for an entire hour about all things fertility. In fact, we previously did a Simon Says series on just fertility. I think we're going to link a QR code here so that you can access that easily. But you can do a deep dive into all things fertility here in this talk and get whatever questions you have answered. But we really we're very intentional about making sure that our patients are connected to resources for sperm banking and egg banking and other more experimental types of fertility preservation if that's what's necessary. So feel free to check out that other QR code, and I'm happy to take any questions that are specific to fertility toward the end.
Excellent. Thank you so much. So, as we might imagine, fertility is not the only thing going through the mind of an AYA cancer patient that might be different from patients outside of that 15 to 39-year-old age range. Because of the time of life of these patients, our AYA folks are often experiencing a number of different life transitions that can really further complicate a cancer diagnosis. I'd like to turn things over now to our AYA and survivorship social worker, Michelle Hoffman. Michelle, we would love to hear from you about why it is so important for AYA patients to connect with a social worker, and also what kinds of questions or support do you find these patients specifically seeking out, and how do we help with that?
Sure. Well, as you said, this phase of life is typically filled with so many big life transitions and adulting decisions, things like starting or graduating from high school or college, living independently, perhaps for the first time, new careers or jobs, new relationships, new hobbies, paying bills for the first time, figuring that out, taking trips. There's a lot of things going on. I think we all remember or know the excitement and fear that can come along with this phase of life. And so, in the midst of it, they get diagnosed with cancer as if their life isn't already crazy enough. Patients say they feel a variety of feelings. Some of those would be anger, confusion, fear. Some say they feel scared, isolated, stressed, overwhelmed, suspended, as if all their previous plans just evaporate, and even trapped. They see life moves on for a lot of their peers and it just stops for them. There is a book I'm going to quickly highlight and reference because I think the words always come best from our AYA patients. This was a book I've recently read, Between Two Kingdoms, a memoir of a life interrupted. The author is, hopefully I'm saying this right, Suleika Jawad. But she was a 22-year-old female, gets diagnosed with AML right after graduating college and living independently for the first time. And in one of her chapters called Stuck, she talks about this place that she's in. She says, with mortality in the balance, one of life's most delicious activities when you're young, imagining your future, had become a frightening, despair-inducing exercise. The future had seemed so infinite with possibility. Now it was shredded in doom, a dark space filled only with the prominence of poisonous treatments and terrifying unknowns. Thinking about the past stirred a nostalgia I preferred not dwell on, a painful reminder of all I had lost. My friends, my youth, my fertility, my mind, as the chemo made me cloudy and slow, and my faith. So again, book, especially for our young adults, a really raw and honest account of her experience with cancer. But in light of all this, my main goals as a licensed clinical social worker are several things. First and foremost are to let patients know that they're not alone. I want to help validate and normalize their thoughts and feelings, letting them know that many other patients are feeling the exact same way or similar way. I want to give space and time to hear their stories, get to know what was like for them or is like outside of the hospital or outside of a clinic appointment, realizing that there's so much more that makes them unique and special that we only see a little glimpse of it, or again, only know them with cancer and not what it was like before. I want to allow them some space to ask questions, especially the ones that are awkward or scary or uncomfortable, and making sure that they're feeling comfortable, empowering them to ask that of their providers and treatment team. I want to help give tools and resources for healthy coping and sometimes brainstorming what that might look like, especially again when life has pivoted and changed so drastically. What can they do now, maybe to practice self-care, or when they're stuck in the hospital or at home or not feeling well? What are some things that might bring them some calmness or some peace or joy? I want to link with appropriate resources and referrals. And then for those who are interested, connect them with other patients. Again, letting them know that they're not alone in this. I do this, social workers do this through a thorough psychosocial assessment. This is where we're asking questions, trying to find out what a patient support system is, how cancer is impacting their life, what questions they might have, if there's any financial or mental health concerns, any barriers to care, or any other stressors that, again, would be helpful for us to know as we help them navigate what's ahead. So what does this look like? Here at Riley, we are doing several things, one of which I'm really excited to announce, is we are going to be offering an online virtual meetup. This is for our AYA patients 15 and up, for anyone across the state of Indiana. So it doesn't matter if you're treated at Riley, IU Health, or somewhere else. We welcome all. This will be, and hopefully either now or later, we will have a QR code and a flyer that you are welcome to. And we encourage you, please help spread the word for us, distribute it to anyone that you know. But the goal is to create a safe space, again, for patients 15 and up to share their experiences, to be able to ask these questions, to hear what others are thinking, and again, know they're not alone. This is something that isn't really going to happen at school or on a sports team when most of their peers have no idea what it's like to be going through this, or maybe even, family and friends. And so it will be moderated by myself or another AYA Riley team member. And then out of this, we hope to offer several in-person activities throughout the year. So stay tuned for those. But May 14th, 8 p.m., and then we are going to get in the rhythm of the second Wednesday of the month offering that. So hopefully that gives, again, more connection. We're also in the process of developing a mentoring program specifically for Riley patients where we make matches. However, there are several national programs that we can and will continue to refer and recommend to families. These are things like Cancer Hope Network, Emmerman Angels, Leukemia and Lymphoma Society has a first connection program for patients with those diagnoses. And then a brand new app came out last year called Cancer Buddy. And that also is a way for people to connect with, you can program in age diagnoses and things like that. Something else that we do is we provide AYA patient bags filled with age-appropriate items. Hopefully they're helpful and cool. Things like nice water bottles and phone chargers and things like that. We also include in it a Elephants and Tea magazine. Perhaps you've seen these in the waiting rooms of your doctor's offices or hospitals. If not, you can get online. There's a way you can get these mailed to your house for free, or there's a lot of online digital content. I really recommend these magazines because they're written by patients, for patients. Again, open, honest, good conversations that can be really encouraging for people. And then we provide out some resources, some newsletters by patients, so some flyers, and again, just letting people know there are lots of local and national resources out there, whether it's Cactus Cancer or Team Cancer America, financial assistance for patients who are in this unique age group. There's also things like camps and retreats throughout the country, so we just want to let people know about those opportunities. So all this to say, I want to encourage patients to be open to talking with a social worker. We are employed by the hospital. We are trained to talk about medical issues and concerns. We are here for you. Every patient is unique, so we realize all of your concerns are different. And if you haven't met one, I encourage you to ask your care team. I know the adult world is quite different than the pediatric world where we're assigned to families by diagnosis, but you might have to ask for one in the adult setting. And if for some reason your care team doesn't have one available, then I encourage you to connect with your area's local cancer nonprofit agency. There are great ones scattered throughout the state. These would be places like Little Red Door, Cancer Support Community, those in Indy, Cancer Services of Northeast Indiana up in Fort Wayne. In South Bend, there's Riverbend Cancer Services and Nick Foundation. There's also Cancer Pathways Midwest in Evansville, and then Cancer Community Cancer Network in Lafayette. So again, there's a lot all throughout the state, no matter where you're listening or getting your treatment. And if for some reason you're from a county that doesn't have one, then there are great national nonprofits with hotlines that you can call to talk to a clinical social worker or a licensed mental health professional. And those would be through places like Cancer Care or Leukemia and Lymphoma Society.
Thank you so much, Michelle. If people haven't already picked up on this, our social worker is a pivotal member of our team. So Michelle joined us late last year, and we were so excited to get a dedicated AYA social worker on our team because there are many pediatric and adult resources that sort of cross over this age range, but there are many that are now specifically focused on adolescent and young adult patients. And to have someone on our team who is specifically knowledgeable about those AYA resources is just an immense help. And there are things that we can offer at IU Health. And then there are a multitude of resources, like Michelle mentioned, in other places that we can connect our patients to if what we have doesn't exactly serve the need that they're looking for. So thank you so much, Michelle, for sharing all of those resources. We're so excited to have you as part of our team.
Yeah.
In addition to social work, and then as Dr. Skiles mentioned, fertility, we also have another resource that we attempt to connect our AYA patients to as close to diagnosis as possible. And that, you might be surprised to learn, is our palliative care team. So I know for me personally, until recently, the talk of palliative care team was potentially scary inclusion because a lot of us are under the impression that if the palliative care team is involved, then that means the diagnosis is very serious and likely terminal. And that just isn't simply the case. There are so many resources and supportive therapies that our palliative care team can offer to all different diagnoses, terminal or otherwise. So this is another team that we are working to get connected to our adolescent and young adult patients as early in their cancer experience as possible. And with that, Dr. Skiles, can you share with us a little bit about how the palliative care team works specifically with our AYA patients?
Yeah, great question. It's so challenging to help patients understand that piece that palliative care does not mean terminal. Really, when we involve the palliative care team, it is our intent to better support our patients and to really kind of wrap them in somebody who can zoom out a little bit from like the nitty-gritty medicine of it and help you navigate what are your goals? What's important to you? Because as a medical provider, my focus often has to be, needs to be on the medicine of it, but that's not the only part of you. We really want to make sure that, just like Michelle was saying, from a social work standpoint, that we're providing wraparound services for psychosocial factors, that we're also looking at big picture. What goals do you have for your life? And how does all of this treatment interplay with that? And so the palliative care team can be really helpful on the medical front in terms of helping with symptom management. And that typically early in therapy or during active therapy takes the role of really supplementing our plans for pain, as well as nausea or vomiting that patients commonly experience when they're getting chemotherapy. But they also attend to things in the non-medical realm, including things like spiritual distress or psychosocial distress. And we really want to give as much support as we possibly can around these topics for any patient that needs it. But it just so happens that AYA patients tend to have more distress, experience more distress as they're going through cancer therapy than either pediatric or older adult counterparts. The other piece that Michelle alluded to earlier is that there are lots of life transitions that happen in this age range. And really, what that translates to is really complex relationship dynamics as people are establishing their own independence from their parents, or how to be a partner in a marriage, or in an early family. How do you raise kids and parent when you're going through something like this? And really, the palliative care can help with making sure that those really complex relationship dynamics are balanced among the multiple. There are often multiple stakeholders involved in these conversations, and how to make sure that the patient's voice is heard, chief among them. Because I think sometimes our AYA patients, their voice tends to get smaller over time because everybody cares about them, and sometimes the care can be a little bit overwhelming, even though people mean well. And so having the palliative care team involved, we don't typically do that like right at diagnosis, but it's our goal to have the palliative care team connect. And I should mention, this is one of our newer goals that's kind of just coming online. So if you happen to be an AYA patient that's listening and you haven't met the palliative care team yet, it's because this is a recent transition and new pillar that's being developed in our team, is to try to get our AYA patients to be introduced to the palliative care team typically within the first 3 months of treatment. Certainly, if there are needs that come up before the 3-month mark, palliative care is always very welcome, and we are quick to consult them when we need them. And you are welcome to ask for their support too. That's the other thing that I think sometimes our patients don't realize, that it really is okay to ask for what you need. And if you have a need that you don't feel like is being met, vocalizing that and being an advocate for that is so much appreciated, honestly, by your care team, because it helps us care for you better. So if that's something that you don't currently have in your care that you feel like you need, my strong encouragement is to vocalize that to your care team, whether that's your medical provider or your social worker or anybody truly that's on your team, nurse navigators. All of us can help you get connected, and really having the palliative care team on board as an adjunct can be incredibly helpful with acute care management, big picture, and long-term goals. So, and if you happen to find yourself in a situation where things are not going well and your cancer isn't responding as you hope, they can also help navigate prioritizing what's important to you as you make decisions about your next steps in care. So I can't speak highly enough about the palliative care team. I think sometimes many patients feel very hesitant about involving them in their care. And my strongest recommendation is that they very often are incredibly helpful in helping to kind of balance things and navigate and keep goals in perspective. So
Excellent. Thanks so much, Jodi. So we've talked about several different areas of support for our AYA patients while they are on active treatment. One thing that you mentioned at the top of the hour as our final pillar is survivorship. So that is how we support our patients once they've finished treatment, once they're designated cancer-free and have rung the bell. I'm going to turn things back to Michelle. Michelle, can you tell us a little bit about what our AYA patients experience through our survivorship clinics?
Yes, happy to. Covering survivorship clinic has always been one of my favorite areas to work in peds oncology, because this is a place where we get to celebrate with patients and their families, kind of this mountain, the other side of their cancer journey, and reminisce with them what they've been through, especially those that we knew who were on their treatment. There's a lot of stories shared, often laughter, and sometimes tears too. Here at Riley, our motto is cure is not enough, as we are aware that there can be medical problems called long-term or late effects that can develop months to years after treatment ends. And for some patients, this is a result of their chemotherapy, their radiation, their surgery, et cetera, received. And some patients also experience emotional trauma from their treatment, what referred to as PTSD. And so, because of that, survivor clinic appointments are very thorough. Sometimes that means very lengthy. So, we want to prepare patients for that. But it's a great place where they can have multiple specialists all there together, kind of this wraparound where we get to focus on them. These appointments typically entail a physical exam by an oncology provider with special attention to body areas that have been impacted by their cancer and making note of any concerns. They often entail labs or scans or imaging, making sure no other relapse or concerns. Referrals are made to other providers if they're not there in clinic. If there's any symptoms noted, these could be referrals to specialists such as cardiology, endocrinology, fertility, or genetics are common ones. They're given a treatment summary. So this is maybe one of the most helpful things we do. So this is a several page detailed descriptions specifically tailored to that patient of, again, the treatment that they received. And so this goes with them. And this is especially helpful if they were much younger when diagnosed. They might not even remember it, or perhaps parents do and they don't, or they've moved and misplaced the files. But this is something that they can hand off to future providers and just empower them with their health history so that they can verbally answer questions too. In our survivor clinic, we also have an educational specialist, and this is someone who specializes in assessing for any school or learning needs, any areas of difficulty. She can help with 504 or IEP, individualized education plans. She writes lots of letters, makes lots of phone calls, and then also has a handy list of scholarships for those of our patients who are wishing to pursue secondary education, because there are some specific ones for our cancer survivors. We also have a nurse navigator who corresponds with patients in clinic, answers questions over the phone outside of clinic, keeps us all organized, clinic flow going, and makes sure, again, that patients are getting all of the correct labs and imaging and things like that that they need. And then there's me, social work. So in Survivor Clinic, I am using validated screening tools to assess for anxiety, depression, and even suicidal ideation, as we know that those rates can be increased in this population. When appropriate, then I'm linking with counseling referrals, talking to them about options, oftentimes close to home, according to what part of the state they live in, what type of insurance they have, and things like that. Assessing any barriers to care or a medical adherence that they might have, and talking about transition when the time comes up. Do they have insurance? Do they have a primary care provider? Making sure they're knowledgeable about their healthcare needs. So our goal is to give patients the tools and information for managing life with whatever obstacles they might have as a result of their treatment, but also giving them hope for their future and hopefully maximizing their quality of life for whatever time that is. So in summary, I just really want to highlight that we encourage all patients off treatment to receive their annual follow-up in a survivor clinic or with their oncology care team, or with a primary care provider if they've already transitioned, and just to really advocate for any health needs that they're experiencing.
Awesome. Thank you so much, Michelle. So hopefully it is clear to those of you on the session today that we are really trying to grow and expand our program to cover all of the stages from initial diagnosis through the end of treatment and then after treatment as well. So I will go ahead and put the slide up now for how to contact us. The best way to reach our AYA program is just through our email address. That comes directly to me. So you're welcome to follow up after today or anytime in the future if you have additional questions, need some additional information, are looking for specific resources, etc. We are always happy to help in any way that we can. And also on this slide is the QR code for the monthly AYA Connect sessions that Michelle is starting up for us next month. So again, those will be starting on May 14th, and going forward, they will be the second Wednesday of each month from 8 to 9 p.m. Eastern via Microsoft Teams. Michelle will be our moderator. And just one note, once you hit the QR code, that starts the registration process, but you may need about 24 hours to get through the full registration process and to the point of getting the link to the meeting. So just wanted to give folks a heads up that it's not a situation where you can just hit the QR code and join at 7:59 on the second Wednesday of the month. There is a bit of a registration process ahead of time, but we would love to have as many of our AYA patients join us as possible, because that is one of the things that we hear the most, that our patients are really looking to connect with other patients who can understand what they're going through, which is why this is a big focus of our program. Getting the mentorship program up and running is another focus, and getting some in-person meetings and events going in the future is another area that we're growing as well. So with that, thank you so much to Jodi and Michelle for everything that you have shared thus far. We have received some fabulous pre-submitted questions, some of which altered a little bit of our content today. So hopefully we've covered them, covered some of those for you. And we will address as many of those as we can in the remaining time that we have. Before we dive into those, though, I want to invite anyone who's on the call today to submit any questions that you have now in the comment box below, or if you are on Facebook, you can submit questions in the chat, and we have someone who is monitoring those for us and getting them over to me so I can then share them with Jodi and Michelle. And like I said, we will cover as many of those as we can. So we've got a couple of questions coming in here, and I'm going to be comparing those against some of the questions that we received previously. One question that we just had here is, what are the resources that we provide for young adult patients with autism who need more supportive care, including not only support with understanding their diagnosis, but also potentially behavioral support? And I will leave that up to either Jodi or Michelle to take, because I'm guessing you both have potentially different perspectives of experience on that.
Yeah, I think this could fall solidly in the realm of either Michelle or I, either the medical or the psychosocial side. I think the shortest and direct answer to your question is that we are accustomed to providing additional support for patients who have special needs like autism. And many times for patients with special needs, what they need more than anything is time and understanding, which is often better afforded in the pediatric space than in the adult space. That said, the flip side of that is we also want to make sure that the providers caring for the patient have the expertise needed to care for that diagnosis. So we just recently had a similar situation come up where there is a young adult patient that really could benefit from the psychosocial support that's offered in a pediatric space, but has a diagnosis that pediatric oncologists don't feel comfortable treating because we don't have any training on it. And I think these are, honestly, if I'm being really transparent, these are some of the hardest cases because we want to be able to do everything we can to best support that patient. We take a lot of extra effort and steps through, I'll speak specifically to the pediatric space, which doesn't perfectly translate to the adult space, but we do have something called Child Life in our program, which, like I said, does not translate well into the adult world, but they have, in the adult world, they have something called Complete Life, which I think helps address some of the same issues, which is making sure that we are as gentle as we can be and as intentional about preparing a patient for what is coming in their care. And that can be like big picture coming in their care, or can be very concrete and immediate. Now we need to access, now we need to put in an IV to get access for your chemotherapy, and really preparing a patient for that, providing them appropriate support through procedures, appropriate distraction as needed. Sometimes we even use medications to help support with that. And depending upon the degree of need, that can be challenging as well. But those are some of the tactics that we employ. Michelle, I don't know if you have additional things that you would add to that.
Yeah, I think the only thing I'll add on is that oftentimes they have the autism diagnosis before the cancer diagnosis. So we're going to connect with whoever their care providers are with that. So if that's through an ABA center or team. And so I've had patients where, it's connecting phone calls or even having those behavioral analysis or providers coming to clinic and walking through their clinic appointment and then helping educate us on either calendars or scripting or how we talk to patients about stuff. So we're really trying to, full circle carry that out with what we do with what's already been successful or helping them, and then making sure the parents or guardians, everybody is part of those conversations to support. But as Dr. Skiles mentioned, with child life, with psychology, really being interdisciplinary and making sure that we're all part of that conversation.
Thank you both. We had a couple of questions submitted prior to today's session that were coming from the family or caregiver perspective. So I wanted to share a couple of those. Michelle, one of the questions that we had come in prior to today's session was, what are the best ways community or family members can support these patients, not monetarily? Can you share a little bit with us on that one?
Yeah, this question gets asked a lot. And the best simple thing I often say is just don't be silent. I think so many of us are afraid to say the wrong thing, or we feel scared or overwhelmed about it ourselves. So people then don't say anything or do anything, and that can make an AYA especially feel more isolated. There are no magical words. There's no right words. Believe me, I wish there was. I've gone to plenty of workshops, especially when I was new, thinking, like, what's the right thing to do or say? I just want to get this perfect or right. And again, the key takeaway is just being present, being willing to be part of this. A good place to start is by asking questions. Simply let them know that you're thinking of them and listen. This is when we want to um, keep our mouth shut, listen with our ears, don't try to give advice unless asked, but really let the AYA do the talking and the leading. It's also helpful to offer help with specific tasks. So oftentimes patients are so exhausted or overwhelmed or don't even know sometimes what their next few days or weeks will look like based on their symptoms or where they're going to be and they're inpatient, outpatient, things like that. So if you know of something that you can do, it's really helpful to offer that specific thing. So think through your life or your schedule. And if that's something like dropping off one of their favorite meals, send a text and say, hey, could I do that on Friday, Saturday, or Sunday? Versus just like, I'm here if I need you, kind of those open-ended things, kind of puts the burden on them to come up with it. But if you can offer some of these things, patients say that means a lot. Things like, getting their schoolwork or taking notes in classes, driving them to appointments on certain days of the week that you might know you're available or have off, walking their dog or feeding a pet or things like that. That can mean a lot. And then staying in touch. These days, it's really easy to do with all of the different virtual ways that we can, whether it's a text, an email, a phone call, a personal message, things like that, sending cards, sending pictures. It's helpful to let them know that they're missed and still being thought of. Well, again, this idea that life moves on for everybody else but them. And so I think sometimes people worry they'll like feel too left out or an accident, like they want to be a part of it. So keep them included, invite them to activities when they're feeling up to. Sometimes it's hard for patients to re-enter or re-engage in things when they feel like they've had to withdraw or be isolated for a period. So be that friendly face that's welcoming to them when they can show up in class or a job or a sports team or church or, you name it, to whatever social thing. Be patient with them. And then, use humor, encouragement, sarcasm for those who like it. And just keep up the communication. And then, care packages, everybody likes care packages. It can be small things, candy, snacks, gift cards for carry out, stuff like that. And then I think the final last thing I have about this is just respect their privacy. So ask what information they want shared with others. Maybe some people really don't want that. It's their story, it's their information, especially for AYAs. This helps gives them some autonomy and choice when so much else has been taken from them. So it's helpful if you ask that too.
Great. Thank you. And shifting the perspective just a little bit, what helpful tips can you offer to parents or spouses, other caregivers who have an AYA patient in their life that they are trying to help support? What kind of tips can we give those folks for maintaining good mental health while they are helping to care for maybe their child, maybe their spouse, maybe just a young person in their life?
Yeah, this one's hard. It's hard to practice what we preach sometimes. And there's that analogy of always putting on your oxygen first. And I'm guilty and not doing that very well myself. But this is when it's really good to try to accept help, to ask for help, and not feel guilty about practicing self-care. Again, leaning into some of the things I said for patients is really helpful for caregivers too, just due to the exhaustion emotionally, physically, mentally, spiritually, all of that. And so this is when, think about things. Again, easier said than done. It's so hard to create time and space to do this, but even just short practices, a few minutes a day of whether you like to read or take a walk, sometimes just orienting yourself to life outside of the medical environment. Fresh air can be really good for that. Exercise, eat a yummy food or snack, journal, pray, read, just stay connected to those outside. There are some cancer organizations that offer free massages. So if those are available and you can get yourself there, by all means, take advantage of that. And then try to find people that you can honestly talk to, whether it's a spouse, partner, friend, someone already in your orbit, or we're saying of connecting with others. A lot of times this is when families say, caregivers or parents, that it's really helpful to connect with others who are walking in similar shoes. And so, utilizing in-person support groups, or there's a lot of different parent groups out there that you can virtually connect with too.
Great. Thank you. Okay, so I know this one definitely goes to Dr. Skiles. This one came in just a couple minutes ago. May I inquire how you manage ototoxicity associated with chemotherapy? Is audiology involved? We are seeing many testicular patients in AYA population with hearing loss. This is very challenging for them during survivorship.
I agree. It is very challenging. This is such a hard topic. So, the ototoxicity is caused specifically by a class of anti-cancer agents called the platinum class of chemotherapy, which is very heavily utilized in patients who have germ cell tumors or testicular cancer. And we know that this is a often very substantial part of what patients deal with in survivorship, which I think kind of speaks to what Michelle was saying earlier, that cure is not enough, right? We have a lot of things that we need to help patients address. So I have good news and bad news about this topic. So the good news is that there's a recently FDA approved medication called sodium thiosulfate that can be used as an adjunct in treatment with patients that are getting platinum-based therapy or any therapies that can cause ototoxicity. The not so great news is that the FDA label indication for that treatment is really for patients age 1 to 17. And really limited to patients who have localized solid tumors. And you might be saying to yourself, why would you do that? Why would you limit to that patient population? And I think the reasons for that are twofold. So in terms of the age limitation, we know that younger patients having intact hearing is very critically important for learning and social emotional development. So I think that's part of the impetus to focus in the pediatric population. But I think we can all attest that hearing is important for all of us. Being able to interact with the world around us with intact hearing is important regardless of your age. So I think that is challenging, that the FDA label is only up to age 17. And then the other piece that is restricted there is for patients who have localized solid tumors. And the reason for that is because patients who have more advanced cancers are more likely to have terminal diagnoses if they are not fully treated. And when we really think about, what are most people's primary goal of cancer therapy is to be cured of their disease. There certainly are dosing modifications that can be made if a patient starts to exhibit signs of hearing toxicity. The dosing of the platinum can be reduced, but it is with the risk that maybe then you aren't fully treating the cancer. So that is the really hard part. In terms of audiology involvement, in my experience, mostly where audiology comes into play is in helping fit with adaptive devices. So typically this is what we call sensory neural hearing loss, which means it's typically the high frequencies that patients have a hard time hearing, but sometimes it can be profound and affect all frequencies of hearing. And so often these patients end up getting adaptive hearing aids that help them interact better with the world around them, but the toxicity is very real. So I wish that I had like a happier, more rosy colored answer to this question, but I think the hard part is that we know that platinums are critical for cure. That is one of the things that is very clear. So I think if it sounds like the person that might be asking this question is a provider. And so I think part of the impetus is to kind of have open dialogue about the anticipated toxicity of therapy and appropriate goal setting for the patient and ask what's important to them. Because there are some people that might say, I will take the potential risk of decreased chances of my cancer not coming back at the expense of I want to maintain my hearing. So I think just having very direct and open conversations. And in general, I would say that that's always the best approach if possible with AYAs, because there is no substitute for having a really solid, trustworthy, open, honest relationship with AYAs. They can smell dishonesty, I mean, better than anyone I know. And they are not afraid to call you on it, and that's appropriate. So I think being really as transparent and honest as possible. I always say in my care with patients that when it comes to hard conversations, clear is kind, even when the information is hard. Because if you're not clear, that's also not kind. So I wish I had a better answer, but that is the harsh reality. And this is why clinical trials are really important, because we won't even know if we don't enroll AYAs on clinical trials, maybe AYAs are more susceptible. Maybe that's why we're seeing so much ototoxicity in this patient population. So if they're not enrolled on clinical trials, we can't do better if we don't know that we need to do better until it's too late.
Thank you so much. And one thing that you said there, I think, is a great point to end on. Clear is kind from the provider perspective, and also for our patients and caregivers, ask for what you need. Don't be afraid to ask for what you need, because we really want to give that to you if we can. So with that, thank you both so much for all of the information that you've shared with us today. Thank you to everyone who has been on the participant line and is still hanging on there. You can find a recording of today's session as well as the fertility session that Dr. Skiles referenced earlier, and also information about upcoming sessions at cancer.iu.edu/Simon Says. And with that, we will wish you a great day, and thanks so much for joining us. Take care.